Bueno, buenas tardes de nuevo. Vamos a dar paso ya a la parte científica del 14 Congreso y vamos a empezar con las conferencias inaugurales. Es para mí un placer tener aquí hoy como primera conferencia inaugural clínica a Paul Sachs. Voy a pasar a inglés para que entienda las cosas que digo, aunque él entiende bastante español. So Paul Edward Sachs is the Clinical Director of the Infectious Diseases Division at the Brigham and Women's Hospital in Boston. He's also a professor of medicine in the Harvard Medical School. If you deal with HIV patients, it's not easy not to run into Paul on a daily basis. If you check up to date because you have a difficult patient, you want to see the latest research on clinical management of HIV patients in up to date, he's one of the editors of the section. If you read a paper in Clinical Infectious Diseases, in one of the best journals in infectious diseases, he's the chief editor of Clinical Infectious Diseases. And if you read about, in general, about infectious diseases, you will end up in his blog, HIV and Infectious Disease Observations, that I will really recommend you to read it. His research is focused on antiretroviral treatment. He's also an expert on pharmacoeconomic analysis of antiretroviral therapy. And on a more personal note, I don't know of anybody more enthusiastic about infectious diseases. He has this contagious enthusiasm. I know many people that I want to be like Paul Sachs. And he's a fan of tennis and dogs. And the best thing of all, he has a great Twitter account. I have not seen anybody criticizing him still. I'm counting. So Paul is going to talk about the future of HIV treatment. And thank you very much, because Thursday was Thanksgiving. He made the effort to come here. And also,
thank you.
Thank you.
Muchas gracias, José. Voy a hablar en inglés. So it is a great honor to be invited to this program. I am delighted to be here in person. I also am delighted to be here with my friend, José Rivas. And as you have heard, I'm predominantly a clinician and a clinical researcher. And in addition, I spend my spare time writing and editing. So I think it's worth my starting out by summarizing why I am talking about this topic today. And the answer can be seen on this slide. Why this topic? I received an email from Jose saying, as one of the meeting co-chairs, I would like to invite you to our 2023 GAVIOTA meeting taking place in a wonderful city in Spain, La Coruña, and indeed it is wonderful. The topic would be Heart, Art, 2DR, LA Art, what acronym is next? And I think that will be for us to decide over the next few minutes. So this is what I'm going to talk about. I'm going to take a brief look back at what we've accomplished, because it's amazing and a miracle. I will briefly summarize where we are now, and then look ahead, what we're looking forward to. Periodically, I might stop and ask some questions. And I will, of course, use many acronyms. I think it is worth starting out just by saying that the word AIDS is an acronym, standing for Acquired Immune Deficiency Syndromes. And this paper from JAMA in 2001 reminded me of what it was like to practice HIV medicine before 1996. The median survival of our patients with AIDS before 1996 was less than 2 years after an opportunistic infection. This is extraordinary progress, and that was extraordinary tragedy. So now my first question for you, and you can raise your hand, because I can see you out there. When did you start your work as an HIV specialist? Raise your hand if it was before 1996. Raise your hand if it was after 1996. So the youngsters outnumber our old-timers here by quite a bit. But I did want to point out in this picture, which includes a certain someone right there in the front, that's me, I also had the pleasure of working with Dr. Trip Gulick and Dr. Joe Aron, and we chose to focus on this area because we thought this was a place we could make the most progress. And indeed, my colleague, Trip Gulick, my co-fellow, was the first author on this paper, which was first presented in 1996 at the Vancouver AIDS meeting, showing that combination antiretroviral therapy with indinavir, zidovudine, and lamivudine led to durable virologic suppression out at 52 weeks, and it brought us the acronym highly active antiretroviral therapy. I'm going to say one of my pet peeves is I don't like using that term any longer, because think about it. We've had highly active antiretroviral therapy for 27 years. So all antiretroviral therapy should be active now, and if it's not, we're not using it. So the treatments were bad, but we knew we could accomplish durable virologic suppression, and that motivated innovative drug development. And I've listed what the highlights are through 2007 with raltegravir, and then, in addition, co-formulations. And now I'm going to ask Dr. Arribas a question. Ready? What are these two regimens? Okay, this one he got right. This is tenofovir, emtricitabine, efavirenz.
Okay.
How about that one?
I think that looks like saquinavir.
Saquinavir, soft gel saquinavir.
D14?
Nope.
No, I don't remember.
Zalcitabine, or DDC, and the other one is zidovudine. That was 27 pills a day. In fact, there were people taking these because they had no other choice. And yet now we're on to the next acronym, which is 1 pill a day, which is sometimes called a single tablet regimen. Now, we don't use TDF, FTC, efavirenz very much anymore. Most of us are treating our patients with integrase inhibitor-based regimens. And this integrase-based regimen, bictegravir, FTC, TAF, we have 5-year data from 2 prospective clinical trials. And nobody in this study who's been taking this regimen has failed with resistance. Nobody. And in addition, drug discontinuations due to side effects have occurred in less than 1%. So that is extraordinary progress. I went through it very quickly because I want to cover the future. I want to mention also that this is not just in Europe, North America, Australia, and other developed countries. This is the tragic figure of the decline in life expectancy in sub-Saharan Africa with the spread of HIV. And this is the reversal of that decline with making antiretroviral therapy available. And why is that? It's because of this regimen, the next acronym, which is TLD. TLD is not available in the United States, but it is very available globally. I heard recently that there are 23 million people in the world being treated with dolutegravir-based regimens right now. That is just extraordinary. But antiretroviral therapy has limitations. And if you did not see Dr. Arribas' sensational summary of these limitations that he presented at EACTS this year, I highly recommend it. I'm sure he has a video he can share with you. It was really terrific, and I don't want to steal what he said, but instead I want us to play this game. We want to think about the future. And so I got some help from my infectious disease colleagues, Imagine you're seeing a person with HIV in 5 years. It's almost 2029. What will be available as the very best, the most cutting edge, and the most effective HIV therapy? Think about it. Well, one person I know answered, Dr. Arribas answered, and he said, oral, once weekly, zero resistance, or OO0. That's a good idea, okay? And then I got to cheat a little bit because recently Dr. Tony Fauci visited us at our hospital. He gave medical grand rounds, and I said to him, what do you think will be cutting-edge, state-of-the-art antiretroviral therapy in 5 years? And he gave me his answer, which I will share with you shortly. But now I'd like you all to vote again. Imagine that you have a time machine, and you're traveling to the future, and in 5 years, you can prescribe any of the following, and you can vote for more than one. So, one would be an inexpensive, generic, one-pill treatment that right now is standard of care, but then costs almost nothing. Do you think we'll be able to prescribe that? Raise your hand if you think, yes, we can. You probably can already. Can you in this country? A very inexpensive one-pill treatment, okay? The next option, Dr. Arribas' choice, one pill, once weekly, oral antiretroviral therapy with no resistance. Will that be available in 5 years? Raise your hand if you think so. Okay. Next choice, a long-acting treatment with broadly neutralizing antibodies by injection twice yearly. How about that one? Okay, we have some optimists. How about a treatment that reverses abnormal immune activation and inflammation? Any takers for that one? Okay. And then last, a practical strategy for HIV cure. How many think we'll have that in 5 years? We have one person in the back who raised their hand. I'm just kidding. We can all be hopeful, right? It's aspirational. So let's take a look at these options and see which one is most likely to be available. I'm going to start with this one. These are our most commonly used treatments globally. Bictegravir, FTC-TAF, TDF, 3-TC dolutegravir, or TLD, and dolutegravir lamivudine. And there's a reason why we all use them. I've just listed the reasons here. They are familiar to all of you. These treatments are extremely effective, very well tolerated, active versus Hep B, high resistance barrier, so many advantages to these treatments. However, there are so many advantages to these treatments that we have kind of reached the top of this asymptotic curve when it comes to one pill, once daily treatments. So yes, over time we can make more progress, but I don't think the progress is going to be very much, which leads me to discuss a couple of one pill daily treatments in development. One of them is doravirine and islatravir, which has already been tested against bictegravir FTC-TAF for initial therapy. And it was non-inferior for virologic suppression. There were about 300 people per study arm. One person in the doravirine islatravir arm had treatment failure with resistance versus 0 in the bictegravir arm. Both treatments were well tolerated. There were no differences in weight gain or any of the metabolic or other effects. And the only difference between the two regimens was that there was the expected suppression of lymphocyte count and CD4 cell count in the islatravir arm. And so the study is now ongoing with a lower dose of islatravir. So that's one of the one pill options in development. The next is bictegravir, the integrase inhibitor, with lenacapavir. And in this study, it's being tested for people who are taking complex regimens due to resistance. So people on, for example, boosted protease inhibitors, plus an integrase inhibitor, plus nucleoside reverse transcriptase inhibitors. Can you just substitute this simple pill for those complex regimens? And that study is ongoing. However, I will say that we already have evidence from this study from Kenya that people in this category frequently can maintain virologic suppression just with TLD. Now, some have looked at this study, which is a randomized clinical trial, and said, but they didn't assess for drug resistance, but we know from other studies in this population that they likely have extensive degrees of nucleoside resistance, and yet they maintain virologic suppression after the switch with no emergence of resistance to integrase inhibitors. And as yet, I'm only available of one case of a person with virologic suppression who has developed resistance after switching to bictegravir, FDC-TAF, or dolutegravir, TDF, lamivudine. Only one, and it's not clear whether that patient truly had integrase inhibitor full susceptibility at baseline. If you are aware of such a case, please let me know, because it could be that I just haven't heard of it. But people who are virologically suppressed have been able to maintain suppression with dolutegravir and bictegravir plus 2 nucleosides, provided they are fully active integrase inhibitors in the regimen. So this does bring us to a potential challenge for future regimens. There are people who have resistance to second-generation integrase inhibitors. This is a multi-site cohort study of nearly 600 people who underwent genotype testing while being on a dolutegravir-based regimen. And they found a small number of people who had dolutegravir resistance. And the risk factors included dolutegravir monotherapy, not surprisingly, dolutegravir dual therapy, and pre-existing NRTI resistance. Now, this is a very small cohort. I just mentioned there are 23 million people taking dolutegravir-based regimens, and this is 599 people. What I'm hearing from people who do work in sub-Saharan Africa, that they are starting to see dolutegravir resistance emerge, but it's not clear to me whether it's emerging at a higher incidence than we're seeing in cohorts like this, or whether it's simply that the denominator is so giant that that's why they're seeing increased numbers of cases. But nonetheless, this raises the question of, will we need some future regimen that is active against people with integrase resistance? So I'm going to sum up this section by saying, let's assume that we eventually have doravirine islatravir and bictegravir lenacapavir as one-pill regimens. Are there going to be characteristics with these one-pill regimens that distinguish them from other options? And I really raise the question of whether we'll ever see a one-pill option that's better than the one that we have now. So switching now to Dr. Arriba's favorite, the one-pill once-weekly regimen. I go back to this survey study, which actually is pretty important because it was before FDA approval of cabotegravir rilpivirine. And a group of people with HIV were surveyed and said, you've got 3 choices for switching your current treatment: a single pill once a week, 2 shots every 2 months, or implanting and removing 2 small plastic rods every 6 months. And the most popular option for switching was the one pill once a week option, which has motivated drug development in this area. This is the furthest along of these regimens It's lenacapavir orally with islatravir. And the islatravir dose, you'll note, is 2 milligrams a week. And it is currently being studied in this phase 2 trial, which is taking people with virologic suppression on bictegravir FTC-TAF and randomizing them to remain on bictegravir FTC-TAF or to switch to this separate pill of islatravir lenacapavir. So that's the furthest along. But there are several other drugs that are being developed for once-weekly therapy, including integrase inhibitors, NNRTIs, capsid inhibitors, and maturation inhibitors, and several studies that are planned, at least, with lenacapavir. Now I'm going to switch back to Tony Fauci, because this was his choice, long-acting ART with broadly neutralizing antibodies by injection twice yearly. And why did he choose this one? He chose it because he's concerned about the population of people we're not reaching, the people who are unable to take oral ART, the people who never take oral ART, the people who drift in and out of care. This group of people in our care cascade, and globally a much larger group of people who somehow can't access these miraculous therapies we have. It brings up the issue of using long-acting regimens in people without virologic suppression. And I want to quickly summarize what has been published or presented on using long-acting drugs for people with viremia not taking oral ART. This is not a licensed indication. This is done completely because the option was no treatment at all. And we know from UCSF now for a couple of years that they've had high level of success using cabotegravir rilpivirine in people with viremia. We have a smaller series from a different part of the United States, but also a very difficult to treat patient population. I think it's important to note that 5 out of 12 had prior AIDS-defining opportunistic infections. And then most recently at ID Week, a cohort analysis looked at people with viremia who started cabotegravir rilpivirine. Now, we have the least amount of information, granular information about this last group. And I want to say I am actually concerned about use of cabotegravir rilpivirine in clinical practice in the United States. Because if you look at the median CD4 cell count for this cohort, it's 401. So these are not people who are in imminent danger of getting AIDS complications. These are people who are all over the place as far as their immunologic status. The interquartile range was 228 to 664. This is not how we should be using cabotegravir rilpivirine. Now, I have taken the liberty of writing some guidelines for use of cabotegravir rilpivirine in people with viremia, and I'm going to share them with you now. This is my opinion, just my opinion. Under rare circumstances, long-acting cabotegravir rilpivirine can be an option for people with virologic failure when no other treatment options are available or effective. Such treatment must be accompanied by intensive case management and close follow-up. It should be limited to people with HIV who meet the following criteria: unable to or cannot take oral ART, at high risk for HIV disease progression with a CD4 under 200 or a prior history of AIDS-defining complications, have virus susceptible to both cabotegravir and rilpivirine, and can be supported by intensive case management services. I'm hopeful that our guidelines will allow this soon. My understanding is that you do not have the option of using this treatment in this context in Spain. Is that correct? You can. Okay, not the label. The label does not allow it. I am hopeful that we're able to get a label change. But that brings us to the question, well, what about longer-acting treatments? What about a treatment you can give to people every 6 months? The closest we have is this proof of concept study that was presented at CROI this year, using lenacapavir every 6 months with broadly neutralizing antibodies, 2 of them, They're called tab and zab, so you don't have to say the whole words. And you could look at this in a glass half full or glass half empty way. You could say the glass is half full. There was 18 out of 20 were successfully treated. But the glass half empty would say that of the 124 people who screened for entry into this study, only 55 had fully susceptible virus to the broadly neutralizing antibodies. And in addition, the patient population they chose for this study had long-term virologic suppression and and never had a low CD4 nadir, and had a CD4 greater than 500 at entry. And there was one patient still who failed with virus that was not susceptible. So broadly neutralizing antibodies are really exciting scientifically, but clinically, they're still not quite there yet. And by the way, no, I cannot pronounce teripalimab and zimlimumab. See, I told you I can't pronounce it. And that was a text I received from my colleague after this study was first presented. He was kidding. All right. So there are other drugs being formulated for longer acting intervals than 2 months, including a form of cabotegravir, perhaps for as long as 4 months, very long-acting integrase inhibitors, other broadly neutralizing antibodies, and capsid inhibitors. And we're hopeful that this long-acting injectable treatment will also have a high resistance barrier. I do want to cite this editorial because I commissioned it. I contacted Laura Waters, and she chose Dr. Arribas as one of her co-authors, and it's called Broadly Neutralizing Antibodies for for HIV Treatment, Broad in Theory, Narrow in Reality. The limitations of these BNABs are the current need for primary resistance testing, the still unclear number of antibodies that must be combined, the lack of penetration into anatomical reservoirs. We conclude that broadly neutralizing antibodies still need considerable improvements before they can be considered an alternative to classical art. And I completely agree, and I'm not just saying that because I'm the editor of this journal. All right. Next, I know you've had Dr. Stephen Grinspoon here. It's about targeting abnormal immune activation and inflammation. I will just tell you, we have had several randomized clinical trials looking at doing something about the abnormal inflammation and immune activation that persists in people with HIV, despite the fact that they have virologic suppression. So far, nothing has worked. Actually, one thing has worked, and that is the statin pitavastatin. When you look at the results of the pitavastatin clinical trial, the benefits of pitavastatin are significantly greater than one would just predict solely from the lipid-lowering effect. However, this anti-inflammatory property of the statins is not unique to people with HIV, and I still think we are going to face a big problem in our healthy people with HIV with non-AIDS-related complications, in particular, non-AIDS-related cancers. So this is a very important study that I believe should be in press very soon at CID, looking at the leading causes of death for people with HIV who are in care. And right now, non-AIDS-related cancers is the highest proportion in this area. And those of you who do HIV care on a regular basis, I'm sure this will resonate with you. This is much higher now than, for example, liver-related deaths, and certainly higher than AIDS-related deaths, which is just this little thin red line at the top. And then the last thing I'll discuss, and it leads right into Dr. Barr's talk very nicely, is a practical strategy for HIV cure. And I have a requisite picture of our first person with HIV cured who sadly died in 2020 of cancer. I have this slide from Steve Deeks, who was very kind in sharing with me a lot of his information. And there have been now 5 people cured and 2 people who seem to have cured themselves. And then there is another person not on this figure who we're still waiting to see whether the remission after their non-CCR5 delta 32 stem cell transplant is durable. I will mention this exciting clinical trial if only to bring up the strategy for HIV cure that some people are championing, and that is to harness the immune system to generate something analogous to an HIV elite controller. And this is looking at a PD-1 inhibitor called budogalimab and seeing whether it induces the kind of immune responses that will lead to virologic control. Very early data was presented at EACTS last month. And here are the data. They used a low dose and found a high degree of receptor occupancy. It was well tolerated in the short term. In some of the patients, after stopping treatment, there was delayed viral rebound. And what the investigators are planning to do is to combine this with an alpha-1 beta-7 agonist to increase expression of HIV antigens on the surface of cells to boost this immune response further. So that is one of the strategies that's being looked at for HIV cure, is enhancing the immune response to create a person who's an elite controller. And the other, of course, is gene editing. And there is now a study in humanized mice finding about 60% of these humanized mice have cleared HIV in the laboratory. Whenever I see humanized mouse, I always think of Mickey Mouse. I can't help it. Do the basic science researchers also have the same response? Anyway, so in this study, they used CRISPR editing of CCR5 and HIV-1 and found 60% of the mice had no evidence of any HIV remaining. And they have started, a company has started a phase 1 study of giving this treatment to people with HIV. They've presented their safety data, their short-term safety data. We do not know what the results will be, if they're doing any treatment interruptions or if they're looking at any reservoirs. Of course they are. Those results are not yet in. However, the concern about this kind of treatment is, of course, mutagenesis. And I want to just summarize the concern raised in this laboratory study, as the loss of chromosomal sequences may cause oncogenic cell transformation. Unintended large deletions form a potential safety risk in clinical applications of this antiviral application, which I agree with completely. So there are enormous challenges to making an HIV cure strategy something that we will one day use in the clinic. First, the off-target effects of enhancing the immune response to the virus have already been seen in other studies of anti-PD-1 drugs. So these autoimmune diseases and other reactions, even using lower doses than are used for cancer. The other thing is that HIV controllers, some of them have actual abnormal immune activation and other abnormalities, and there are even some studies that people who are HIV controllers have a worse clinical outcome than people with virologic suppression on ART, although the data are mixed in that regard. I already mentioned the problem of gene editing and mutagenesis. I think monitoring for relapse is going to be extremely challenging. We have to do analytic treatment interruptions to show that this works. But once we have a strategy that works, what will be the frequency of monitoring of people who've undergone a cure strategy? How will we know when or if the virus comes back? I think pre-exposure prophylaxis raises other questions. If someone is on ART and virologically suppressed, and then they have a cure and they decide to take PrEP, what have we really accomplished by that cure? And then the other thing, just because it's so obvious, is our current treatment is so safe and so effective that this makes any HIV cure strategy that we do very challenging from an ethical standpoint. How do you do a clinical trial and really convey to people the risks of going into such studies. And then last is the cost. So to summarize, we have really excellent treatments now. We should be all very happy about it. We should have a really good time at this conference celebrating our great HIV treatments. However, it's not perfect, and we can expect some incremental advances over the next 5 years. And I put here the ones I think that we're most likely to see, which is once-weekly oral ART and additional improvements in long-acting therapy to extend the dosing intervals. I also am sure we will see reduced costs of treatment. Keep an eye out for integrase resistance and non-AIDS deaths from cancer in particular. Cure remains aspirational. I am very hopeful, and there are more acronyms to come, which means that this cartoon will be prescient. Before I begin, one of the acronyms I'm going to use is completely made up. See if you can figure out which one. So, many thanks to Steve Deeks, John Lee, Cal Cohn, Megan Dominguez, y especialmente al rey de los acrónimos, José Rivas. Thanks all of you.